I would like to talk a little bit about management protocols of nodules, but also incidental nodules. First of all, incidental nodules are, as you all know, highly prevalent in current as an incidental finding on current CT scans. And I also searched in the literature what's the estimated prevalence about it, but the range is quite high. I find estimates between 2 and 59% on CT scan, but this has also everything to do with reporting these nodules, communication about this, but also management of these nodules. Oh, I'm sorry. But the issue is, of course, with these incidental nodules that there's an increase in current practice, mainly because of the current technical developments, of course, in the nodule detection, but also there's a huge increase in the use of CT scan. But the issue also with these incidental nodules is that most of them are benign, so only a few of them really are lung cancer. So the challenge is how to deal with these nodules. And of course, the important thing is that we would like to minimize the harms caused by unnecessary follow-up of benign nodules. Another important issue is that it's estimated that only 30 to 50% of these incidental nodules received an adequate follow-up on time. And of course, there are a lot of nodule management protocols, as you all know, so I won't go in that detail, but this is just an example of the Fleissner guideline. That is one of the few guidelines with a separate part about how to deal with incidental nodules. But just in general, of course, the guideline is to follow up these nodules in 3, 6, 12 months when you are above a certain threshold. Then I would like to go back to the lessons learned with our Nelson trial. What we, of course, there, and you may all know, I guess, that the lung cancer probability depends on the volume doubling time, but also there are differences between baseline nodules and also the new nodules that occurred in the incident screening rounds. And what we've learned there is that it was important to use the volume measurements to have more accurate measurements and also to reduce the false positives and chance on overdiagnosis. But what we also found out is that we really should use different cutoffs for baseline nodules and new nodules on the next CT scans. Also, the use of the volume doubling time is also we find that it improves the risk categorization in these nodules. But what we also have done is that we integrated a new screening test result, the indeterminate screening test result. And we found in the Nelson already about 15% in the baseline indeterminate nodules. And the message there was, we would like to see you back in 3 months. So, and most of the people with an indeterminate screening test result will have a benign nodule. So it also prevents a lot of unnecessary follow-up, but also unnecessary distress and so on. But what have we done with all these knowledge? We tried to integrate that in the long run in our European lung cancer screening implementation trial. And I will not go into all details, but just to give you an overview, we developed a categorization system that looks like the lung rats. We also have a classification between 0 and 4, and then 0 it's an incomplete scan, so we need another scan. And then we have the 1 to 4, in which 1 and 2 are the test negatives, the 3 is an indeterminate, and the 4 is a positive screening test result. But what we have done is that we developed a whole decision tree to systematically analyze the nodules. So we first look at, is there any nodule? So if yes, then the next question is what type of scan is this? Is this baseline, or is this a repeat or annual scan or whatever? Because we have other cutoffs depending on the CT scan that we have. So if there is a nodule, then we focused on the solid component of the nodule. So if it is a solid nodule, then we measure that. But if it is a part solid nodule, then still we focus on the solid part of that nodule. And as you can see, we have no report of nodules smaller than 30 cubic millimeters. And then we have a little bit different thresholds as compared to the Nelson trial based on the information that we got from the Nelson for the baseline nodules. But then we have, of course, also the repeat scans and the annual and biannual scans. And still we focus on the solid parts of these nodules. And what you can see here, and yeah, it's working. But we checked if there is a nodule, whether there's a solid component, yes or no. If there is a solid component, then the next question is it a new nodule, or is there a new solid component of the nodule? And based on that, if it is not a new nodule, then we can of course calculate the volume doubling time, and then we have still our indeterminate screening test result to prevent as much as possible the unnecessary follow-ups. And then what you can see here is that we then, if there is a new nodule or there's a new solid component, then we have other thresholds as compared to baseline. So we know that the lung cancer probability in new nodules, or when there is a new solid component in a nodule, that the lung cancer probability is a little bit higher as compared to the baseline nodules. So our thresholds are a little bit lower. And then we have also a protocol for the non-solid nodules. And what we are doing here is that in general, we have no positive screening test results in non-solid nodules. But what we did is that if there is a non-solid nodule, then the follow-up will be annual or until the diameter is above a threshold of 15 millimeters. Then we will refer that nodule of that individual as an incidental finding. So not as a positive screening test result, to prevent unnecessary that the GP, but also the participant thinks, okay, this is because of suspicious of lung cancer. But now we would like that there is a follow-up, but not as a test positive. What we did in the lung nodule management protocol is so that we are focusing on the solid part of the nodules, but we also focusing on the actionability. So if we think that it is actionable, then follow a referral. But if we think it's not yet actionable or not actionable, then we continue not as a positive, but as an indeterminate. So then follow a repeat scan to follow up and to see what's the VDT after 3 months. And then again, the non-solids, of course, as an incidental finding. And then when we have the nodule management, then another thing that is very important is your data management. And that's also something that would also be important for incidental nodules, and that is that you have all your data ready. So not only, and this is, you can see here, data management for the screening. So screen detected nodules are, of course, different from incidental nodules, but the idea is the same. When you see that you need in an exclusion criteria, you need also risk factors. You need more information of that individual to determine the lung cancer probability. But what we also have, and I have also another slide in a minute, is that we have the decision tree that you saw. We have completely integrated that in the system. So the only thing is that the radiologist has to do is to complete a kind of an online form with some variables. And based on that variables, the system decides what classification belongs to those variables, and then the screening test fields will be automatically determined by the system. And then also, what's also important is that there is a kind of an action after the reading. So if it is negative and there's nothing to do, then in this case, in screening case, you have a follow-up at the next screening round. But if there is a need for referral, if there is a need for a repeat scan, then the system knows that. And then when after 3 months a repeat scan should be planned, then that will be planned so that you ensure your follow-up of the people who needs it. And here you can see a little bit, it's not the whole screen, but what you can see here is that there are 3 nodules detected, so that's in the system. The decision tree determine the classification based on a reference nodule, and this is in general the largest nodule or with the lowest VDT. And you can see the main characteristics, and it's actually in the system there's more. So everything is listed, and then you have automatically your classification and your result, and whether there are, for example, incidental findings, other incidental findings or so that everything is ensure a uniform management of your nodules. And I see that I have less than 1 minute. So in conclusion, also for the management of incidental nodules, it's very important to try to prevent unnecessary follow-up procedures. So a nodule management protocol that combines the nodule characteristics, but also the risk factors of the individual should be very important for the future, how to handle with incidental nodules and to increase the early detection of lung cancer, but while minimizing the harms caused by the unnecessary follow-ups. But last but not least, it's also important that when you have all these guidelines, that there's also compliance in clinical practice of these guidelines and also of the data management that you have around these nodules. So thank you for your attention.